What's good, y'all? It's your boy Herb.
And it's your girl Mo.
And welcome to our soon-to-be world-renowned podcast, Young, Black, and Figuring It Out. What up, though?
What it do?
Whatever we tell it. So, look, we are excited to be here, and I know y'all going to be excited for this because usually we start off right now with the question, what did you figure out this week?
Right.
But we ain't got time for that today. You know why we ain't got time for that today?
I know.
Because we have two amazing special guests joining us today. We are going to introduce in just a second. But to come and talk about one of the, I would say, super important topic,
Yes.
piggybacking off one of our most successful,
Yes.
our actual most listened to episode of season 1.
Being black and white spaces.
Being Black and White Spaces. And so today we actually have Being Black and White Spaces part 2, healthcare edition, right?
Dun-dun-dun.
Super important topic. As I'm actually starting to learn about how important that is. I think we are. And so we're going to bring that to you all today. So we really are excited for you all to tune in. And with that being said, we're going to introduce our special celebrity guests. We got the doctors in the house. The black doctors in the house. We ain't playing. All right, so let me go ahead and pass it off. Got to start off with Dr. Jada?
We can start off with Dr.
Dr.
Jada.
Dr.
Thank
Jada,
you. Yes. So, hi, I'm Dr. Jada Hamilton, a family physician by training. I am also currently serving as a interim medical director at a institution of higher learning at the medical clinic. And another interesting piece, I am a Navy veteran, so I retired from the Navy in 2012. So I did a lot of traveling and deployments and lived overseas, and 3 of my 4 kids actually were born in Japan.
Wow. Appreciate that.
Yeah.
Yes.
So it's been a good ride and helped pay for medical school. So I don't have all that debt, which is lovely. And
Blessing.
so and living in Ithaca, New York right now.
Okay. Appreciate you being here. And I did not know all that history. And thank you for your service and all that you do.
Oh,
And
thank you. Thank you.
shout out to, the low debt. Free, hey, forget the loans, Joe. Well, okay. Okay, Dr. Conyers, can we pass it to you?
Yes, hello everyone. I am Dr. Yvette Conyers, a nurse and nurse practitioner, family nurse practitioner, primarily teaching in academia at St. John Fisher College. I reside here in Rochester. I have 1 son, and I'm excited to be here, y'all. I'm excited to be here.
Yeah,
Welcome.
Yes, welcome. We're excited to have y'all.
That's among greatness. Don't you feel it?
It really is a lot of excellence in the room, and we are excited to be here. Honored, almost. You know?
Almost honored.
Yeah. More than honored.
Where the almost came
What
from.
are they almost honored? I'm not sure about that.
Humbled.
We need a little bit more of
Yeah.
I know, right?
Humbled.
Almost honored.
Humbled. Yeah,
Sorry.
humbled. Hey, listen, you don't know what I meant to say. Definitely honored.
You did this to yourself. I knew it.
Listen, y'all, I'm about to be getting it all day. Okay. But all right, let's dive into this. You know, I really, I think for today, we want to really do a lot of facilitating and listening because you all have had many experiences in both experience in healthcare as far as being folks who have to engage that system, but then also working in that space. So we're excited to dive into it.
Yes.
But first question is, so we all kind of work in an area that focuses on healthcare or health in general. And so just wanted to get the background on what led you all to go into that field. So we can start with Dr. Conyers and then just work around from that.
Sure. So I actually didn't want to be a nurse at first. I actually wanted to be something called a neonatologist, which is a physician who specializes with really preemie babies, really, really small babies. That was sort of my dream. My dream was to go to a HBCU as well. And both those plans sort of took a detour my senior year of high school when I got pregnant with my son, or became pregnant with my son. And from there, I realized that at that time, HBCU just wasn't for me as well as that career path. So I wound up, that summer, still pregnant, doing what I need to do for prereqs. And that fall, I enrolled in Brockport's nursing program, actually, and stayed on campus. 6-7 months pregnant, stayed on campus in a dorm, and which one of my best experiences of my life was staying on campus. And I had great friends and some family members who took care of me. And then from there, just continued down that nursing path. Left Brockport in December, and that January had my son. And then went back to MCC that fall, finished their program, and on and on and on and on. For me, it was important that I was a role model for my son. That I wasn't just at that time going to keep having children. I wanted to marry and all those things. And so that sort of led me on my journey to healthcare. I don't think I called it. I think it was a calling for me at the end of the day. It is something that chose me, and I am forever grateful that I'm a nurse, really touching bodies, healing bodies through the name of Jesus for me. So that's what it's about.
Yes,
Wow,
testimony. Ooh.
that's great.
Yeah. Thank you.
Great.
That's good. That's a great story. And for folks who don't know, so you're DNP, right?
Yeah, DNP. So doctorate of nursing practice. So there's
Okay.
different doctorate levels out there, for nurses. EDD, which is education focused, PhD, research focused, and DNP, which is more clinical focused. So
Gotcha.
yeah,
Wow.
so that's what it is. But, I have a passion for teaching and educating the next generation that's going to go out there and take care of folks the right way, looking at taking care of folks with a health equity mind, specifically focus on race. And so we can talk about that later, but it's important for me to prepare this next bigger picture instead of providing that individualized care.
Okay, appreciate that.
Yeah,
no
yeah.
problem.
Dr. Jada, how about you?
Okay, so wow, that was beautiful.
Oh, thank you.
So I've been doing this for so long. I mean, I think, I don't even want to say when I graduated from high school and college. We're not going to go there right now. But I just remember I've always kind of been the one interested in like science. And back in the day, you could buy these little dissection kits with like a little frog in it and stuff. It was kind of crazy. And I just was always interested in that. And I think that that piece of just kind of helping people, in a way that could, help improve their health and kind of, interested in just kind of disease processes and making people feel better and things. So, I had a few little detours. I wouldn't say a detour. I mean, for like a minute, I thought I wanted to be a lawyer. My dad's a lawyer, and I look at one of those law books. I'm like, yeah, that's not going to happen. And then I think I had a little time when I want to be a fashion designer, but I can't really draw or anything. So I'm like, that's probably not going to work out. So after college, I took a little time off, and my mom lived in Malaysia at the time. That's a whole other story. And then just really said, okay, this is what I want to do, and set out to applied to medical school, got a Navy scholarship, and but I knew that I really wanted to do like sort of primary care, kind of doing a little bit of everything. Just because I think that's the holistic approach that I appreciate. Every rotation I loved. I've been like, oh, OBGYN, obstetrics, but I don't think I could do obstetrics and have all those call nights and staying up and stuff, and then surgery, staying in the OR for 8 hours. I mean, but all that was great. It was great learning and everything. But and I think it fit that I did my Navy medicine because Navy medicine is really full scope. So when I was in the Navy, I delivered babies, did newborn care, assisted in C-sections, of course, did pediatrics and adult care and retiree care and stuff. So I think. It was a lot of fun. I mean, there's always downtimes and struggles and things like that. But and I think that that's also what drew me to college health is that in the military we are there to help support the troops and the families because we want to make sure that they're taken care of so they can the active duty can go do what they need to do. So it's all about keeping them ready and healthy so they can do their job. So same for college students, right? We want them to be able to go to class and get all the, advantages out of being on a college campus and doing their thing. But they have to be healthy and well to be able to do that. And at the same time, we kind of want them to be able to advocate for their own health. Right? So they're at that age where hopefully for the most part, their parents aren't making their appointments and, but so we're hopefully able to do that. And I just, it's fun. It's fun. And it's fun. It's just like the sort of the really great period of life to be able to be a part of and help them stay well.
That's good. And I love both of those too because it's like Dr. Conner, you talked about how that was a passion because of your experiences and what you want to do around health equity. I know that's a passion for both of you all. We haven't dove into that yet, but I know it's a passion. And then you also talked about how you enjoy it, like you enjoy the work for Dr. Jada, which is cool. That's two different lenses, same kind of thing, right? But that's great. It's a calling and a passion and enjoyment.
Yes.
That's good. And you mentioned a few things that I just want to clarify for folks because before I started to work in healthcare, I might not know all these things. PCP, primary care physician, which is like your family doctor.
Or primary care provider.
Provider, okay, got you.
Yeah, it could be a physician.
Yeah,
there we go.
Okay, thank you. Appreciate it. Teach me, learn us
Taught me
something.
that too.
Yeah, because even in my clinic, we work, there's physicians, there's nurse practitioners, there's physician assistants. So there's, just a multidisciplinary kind of group of
Got
people.
you, got you. Folks that people
Yeah.
would experience, like that's who you might go to, like a family. The family would go to see your PCP or go
Exactly.
To, I got you. Okay,
Exactly.
that's good.
Exactly.
You mentioned obstetrics. Was that the word?
OB.
OB.
OB. Help, teach us
Obstetrics.
something, y'all. Obstetrics. Obstetrics. OB.
Obstetrics.
What we talking
That's
about?
why I say OB. I'm like, I'm not gonna say myself.
Yeah. So let's talk about what is that for people.
Oh, so obstetricians are their specialty, OBGYN, and they primarily focus on sort of the care of the pregnant woman.
Got you. Perfect. Okay.
Yeah.
Good. We can stop right there. We ain't got to dive into nothing else.
Don't dive into anything else.
Okay,
We don't have
just go
to.
right there. That's good.
It's
Okay.
important, yes.
Cool.
But it is
Yeah.
important. It
Yeah.
is important.
That's
Yes.
good. Okay. Appreciate that. Yeah. And so, for folks who don't know, do you mind sharing? I know you in health, because before we dive into talking about health, you talk about your
Yes.
focus.
So I'm a school counselor by trade with elementary school students. And I am in school to be a marriage and family therapist. Graduate this month.
Hey, man, let's get it. Yeah.
Yeah, so
Oh my
I appreciate that.
gosh.
So I am focused more on the mental health side of things. And for those who don't know, Monique means advisor or wise counsel, which is my first name. And so I feel like, almost like you said, like it called you. It's like I didn't really seek it out. It so happened that my life landed in that area. And when I ended up coming to college, I was like, oh, psychology. I didn't know what I wanted to do with it. But looking through, past traumas and recognizing that there was a lot that I did not get to unpack as a child, I was like, let me lend that toward children now. And then the more I've been in it, the more I recognize that the family unit is the most essential part when it comes to what's happening with our young people. And so looking into marriage and family therapy in a way where I can help the whole unit. And like, if you can change certain
Wow.
things with the parents, like the whole family kind of thrives. And so that's
For
where
sure.
my
That's
health focus
awesome.
has been. Yeah, thank you.
Love
Oh my
it.
gosh.
Oh man, I feel
So
honored
many
that the
people-
doctors feel this.
The doctors. I mean, we there's such a need for mental health providers of color.
Yeah.
I mean,
Yes,
Yes.
yes.
Yeah.
yes. So I'm so glad that. Awesome.
Thank you.
And also having the conversation that mental health is health. It shouldn't be
Yes.
separate.
Thank you.
Right?
Yeah.
It's not.
Thank
It's not
you.
a separate part. It's part of everything we do. Physical, emotional, spiritual, financial,
Exactly.
Right.
mental.
Yeah.
Exactly.
Yeah. It's a
The
holistic
holistic
approach.
approach.
Yeah. Yeah. I
Yeah,
love
my
that.
brain. Yes.
That's good. That's important. Yeah. So y'all heard about these legends here. So with
That's
that,
right.
and the lens I'm coming from is new. Is so recently I'm the chief diversity officer of a health system out in Ithaca, New York, and so that is a new lens in a good way, which focuses on a couple different things. But I think for the purpose of this topic is health equity, right? And how can we look to provide that for folks who don't get the same level of access or adequate care as many of their counterparts. And if I'm being specific, many of their white counterparts, right?
Right.
Especially speaking of black and brown individuals. And that is across the board nationally. And so that'll be some of the focus of our topic today. And I think for me, the best thing about me and my role is I'm in healthcare, but I'm not of healthcare. I did not come up in the healthcare space.
Right.
I came up through a diversity, equity, and inclusion lens. And so I can relate to experiences that folks may have from a visceral and personal level, different.
Right.
And then kind of use the access and influence to help people change it. So that's
Oh yeah.
that's kind of the lens. So, so with all of that being said, I'm gonna try to add some value in this. But we got some legends in here, right?
For sure.
But
Legend.
so diving into this episode. So today's episode is we spoke about this before we jumped onto it. One of our most listened to episode of season 1. I know people when they hear this is coming out are going to be excited. Being black in white spaces, and this is part 2, the healthcare edition. And so we just want to start with some level setting though. That title is making an assumption,
Yeah,
right? So
Right.
that healthcare is a
Right.
white space. So the first question is like, do we agree with that, right? Do we see it that way? I would say yes, but I want to hear from you all.
Right.
Do we see healthcare as a white space predominantly, either systemically or even just demographically?
So I do think in some ways it's a white space just because of the distribution of, people of color, black people, I'm just going to say black and brown physicians
Yeah.
compared to white counterparts. So the percentages are a little bit different. I mean, we as black people make up about 13% of the population-ish,
Yeah.
and then maybe about 5% of the physicians are black. So it's
Underrepresented.
kind of exactly. So when you think about it that way, it still does feel
Like a
like
white
a
space.
white space. And depending on where you are and where you are in the country, I mean, Ithaca's, you know, there's not the diversity is not necessarily reflective of many of the populations that we serve. So it's kind of, and I'm sure people who've gone to like HBCUs or even like medical school at like Howard or Meharry. I mean, I'm sure that may have a little bit different perspective, but I think when you think about the country as a whole, it's pretty white. You know.
Nope, that's real.
I mean, it's not a bad thing. It's just you know,
it's just
a fact. I mean,
it's a fact. And I think it sometimes can become a bad thing. So we can dive in all that, but so I
mean, that's not a bad thing, but you know what I mean.
Right.
It's just like
it is what it is right now.
It is what it is,
right?
but there's things that we can sort of do or implement to kind of help the balance and the equity.
That's good.
Regardless, so I think there's
You know, Dr. Jada, I was thinking the same thing, and I was prepared, I thought, with an answer. But I think sitting here, I feel like when we look back at slavery, healthcare was predominantly by us, for us. Thinking about our ancestors in the field and the things that they had to do to take care of their families when they were hurt or when they were sick. A lot of those like natural remedies, those type of things were all parts of healthcare.
True.
It's because of access, power, privilege that white people, I think, were then able to use technology and who knows who to really have the infrastructure of medicine. This is just all coming to mind right now, to have that infrastructure of medicine to be able to help them with systems. But we know of historical doctors and nurses who have created things and who are legends, but yet we hear about all these white people. And some of this stuff was just stolen, I think, from Black people and made to leverage the white person and help them financially. But I honestly think healthcare started with Indigenous people and Black people, and then it morphed because of influence and money. And now I think we're at a point where we are trying to get that same influence and money, but because of systemic barriers, it has created the inequities that we see.
That's real.
Yeah, that is real. So it's almost like the healthcare as we know it today might be a white space, but maybe the origins of healthcare wasn't necessarily that. And what we see today is, like Dr. Jada was saying, demographically, because of some of those barriers, some of the folks who look like us don't have access to become physicians or nurses, whatever it might be. Yeah, so it's almost become a white space over time, the way that we have done it. Yeah, no, that's good. And I wonder, piggybacking off that, did you want to add to that too?
Well, thanks. I was just thinking.
Thank you.
I was honestly just thinking, based off of everything you said, it's like, you know, sometimes who wrote the story is who you know or hear about, right? And so like these textbooks are written by certain people and they're based off of certain things.
Exactly.
And so a lot of it is a lack of knowledge about us anyway. And so we have so many providers providing things based off of things that aren't necessarily true or with a lack of knowledge. And I think you see that happen more. So that's why you look for, Black people typically will look for people that look like them, but because of how the system is or how they've been taught, it really doesn't even fit. It's like searching for a mental health therapist right now, literally cannot find one. I asked for a Black person, they had no one. They found one person. I was like,
wow. Yeah.
And not only that, when you find one, it's the training behind it, those principles of like African principles, Black principles that, again, if you're taught white and not taking into consideration the culture, then that is going to have an effect on families and things like that.
So we're like non-existent in multiple ways.
Yeah.
You know?
Right. And for the historical piece, I think, I don't want to quote a time in history, but, you know, there were segregated hospitals, right? So who has the power? It's just about who has the power and influence to be able to say, Black people go in this hospital. So in that environment, it's not necessarily a white space, but it's created by, to, you know, basically retain the white spaces, right? So, it took up some policies to kind of integrate, but still, there was still the, you know, everything was not equal, obviously, in care provided. So
and I think so. I would ask too with that, if it kind of has morphed into this space that's either white demographically or kind of navigated by white systems, like if you created white, what effect does that have on the Black community, right? Having to engage with that. Like, what things have we seen as some of the effects that you always say? So both psychologically or even health-wise, you know?
I mean, just as a patient growing up, I encountered people or doctors telling me that I should be a certain weight based off of my height. And I was like, but what chart did this come from? Because like, if I look at my family size, it's like I'm just thicker. I cannot help some of the muscle mass that is on me. This is just how my body is formed. But to them, I'm unhealthy. And they'll check charts, they'll check blood pressure, everything. And there's never a problem. I was like, am I unhealthy, or is this based off of a standard that is set by someone else?
Exactly. It is.
It's those
my gosh.
things like that happen so often in so many different spaces. And doctors believe that this is true. It can be problematic.
Yeah.
Right.
I almost want to say, do you, dive into that?
Yeah, go ahead, Dr. Jada.
Oh, no, I was going to check my phone because we just had a presentation from our nutrition team about the origins of BMI and how that's a whole. You're absolutely right. It's based off of a whole standard. I mean, there's other reasons why they kind of set that standard, but it's sort of this, white European sort of what that's supposed to look like. But there's a book about how. I was going to look it up in a minute, but but it's yes.
Yeah, and I agree, like the body mass index, right? So for listeners who don't know what BMI is, most people probably know, but that body mass index. But I also think when it comes to like medications, the lack of Black people involved in clinical trials, you know what I mean, to ensure that medications are going to appropriately work, realizing still that race is a social construct, not biological, but there's still some differences in the ways medications may work more effectively for one versus another. I think that's a big thing to consider, as well as, just with any disease process. I think you have seen some disparities, not because of the differences in our bodies, but more so because of those structural systems that have been set up, bias, right? Racism, prejudice, all those things that have an impact on the health of the Black person, including stress.
Right.
You know what I mean? And the compounding effects of stress on individuals can lead to a lot of these chronic diseases. And it's not because individuals don't want to exercise, not because they don't want to eat right. It's about access.
Like, who gets to decide where you're going to put your community's, health center, and in your community, and who gets to decide where you're going to have a nice a grocery store with healthy foods, right? And safe places to like walk, and physicians who actually care. I mean, I'm just So
talk about it.
Right. So I think that. When you think about somebody with, high blood pressure and diabetes, and you think, oh my gosh, you must do this for your diet, you must do this. But if the only like local place to buy food is like the little corner store, then
I'm gonna go what's available to you.
Exactly. And if I have to take maybe, depending on transportation concerns, if I have to take after work, taking a couple buses just to get to a doctor's office because I don't have anybody in my community, then maybe, you're higher risk of having missed your appointment. And and then there's some practices that if you miss your appointment 3 times, and we are disenrolling you from our practice. So I think, there's a lot of things that are going on now, and people to also sort of point to like historical things like Tuskegee and, those kind of things. But that has happened, but there's still structural issues and racism today that affects the care provided to Black and brown people.
And I think we've seen that clearly with COVID, and I know this ain't a discussion for that. But that's just something more recent that people can think on, not think back to, think on, and see how that has disproportionately affected us.
Yeah, 100%. And some of that, so that's how a few of the ways that healthcare being a white space has affected us, right? And I think even too, from a patient lens, just the mindset of how you approach the doctor, right, in healthcare, the things that you don't know and the things that you won't do based on a lot of those experiences. So, for example, for me, going to the doctor, when it came to my pops, listen, my doctor was Shake It Off. Like that was the name of my doctor. Doctor Shake It Off. If something happened, it was Shake It Off. You'll be okay. I mean, a lot of that was not trusting, like, oh, okay, this person is out to scam or swindle. Like, we didn't trust that, so you weren't going to the doctor. It would have to be, it would really be to the point where, even to this day, like when I talk to my pops, something happened, like, oh, I'm going to urgent care. Like he does not have a primary doctor. Like that's what he would do when it's bad, with urgent care, and that is the mindset around health and healthcare in general, right? Is that we don't trust the outcomes. And a lot of that is rooted in things that are tangible. That's not just a misplaced mistrust.
Right.
It's a real mistrust, right? And
For
so
sure.
the space that hasn't looked like us, which hasn't resulted in practices that treat us, then does not invite us to the space. So we don't go as frequently, which leads to so many other things for sure, you know?
Right.
And I don't know if folks here grew up with primary care doctors, but I, not as much. You know, it was, did you?
Not really.
Yeah,
Like
yeah.
I remember I couldn't tell you their names. Like I saw one once every so often, but not to the point where I'm like, I know that who my doctor was, and if I had something going on, I would get taken to the doctor. It's like, no, Caribbean families, they have their own home remedies.
Yeah.
You know, Vicks Vapor Rub took care of everything.
Apple cider vinegar?
All the time.
Who has had cod liver oil?
Yes.
Oh, listen.
Terrible.
Yeah.
Lord.
And I would say, you know, I had a pediatrician, and so I went to my pediatrician, Dr. Weber was his name, part of Rochester General, a long time ago. But I would say when it came to GYN, those were some of the home type of remedies and conversations with aunties and moms and grandparents. You do this, girl, and you need to do this, and you need to do this. And then when I finally got to see the GYN, it was, you know, conversations on, why are you doing that? You know, why are you doing these practices? Or, you know, those type of things. Maybe with a turned up face, but it's like some of this is just, you know, the way we were taught and cultural and things like that, which
Right.
Yeah.
I didn't even know that was a doctor for I don't know how many years. It's like, what? You go to the doctor for this?
Yeah, as you saw, I didn't even know the real name of it.
Yes.
I'm like,
I know, like, what's that?
that's what it is. OBGYN. Listen, come
Adult
on.
me had to choose to go. I was like, right. Yeah.
That's big. And you know, I think, and a lot of times when people, and I've been trying to be more clear when I say people who look like us or look like them, because people almost take that literal, like it's just about the skin color. It's like, no, it's a shared experience that we say, oh, this person can relate to these experiences. And not just because we're a monolith, like everybody does the same thing, but the world treats us in a similar way.
Right.
So we have to experience the world in that way. So that's what you're saying is the things that your doctor say, why are you doing that? It's like, okay, they don't understand the cultural practices as to where someone who has your shared experience, who looks like you, can relate to that, you know?
Right.
And I think that's kind of what we're saying is why we need more physicians or providers of color, because they can relate in that way. And I almost want to, it's not on the list, but I want to tangent.
A tangent.
Can we talk about why the importance of, like, if you were talking to our folks, our people listening, the importance of having, you know, a primary care provider or like getting regular, all of those things, like, why is that important? How is that important? What should people be thinking about or doing?
So, I mean, one thing that comes to my mind is, you know, prevention, like of, you know, chronic disease. I mean, I think, you know, if you have somebody that you trust, you can go to and get your, you know, checkups and things, you know, that you can prevent or, you know, stave off things like complication from diabetes or even diabetes itself. I mean, you know, or hypertension or catching things. Talk about like, you know, your mammograms and your colon cancer screens and things like that. So having someone to go to sort of, you know, keep you in check, keep you sort of making sure, and even for the health, you know, the mental health part of this. I mean, just, you know, having someone to talk to and work out sort of possible, you know, if you need treatment or therapy and things like that. I mean, a lot of primary care providers, you know, treat mental health. I mean, mental illness and depression with medicines and, you know, provide, you know, referrals for therapy and things like that. So I think it's important. But I think also people can, you know, if you don't jive with someone, you can always change.
Yeah.
But I know that I say that knowing, of course, acknowledging that in some areas where there may be limitations or limited services or limited access or one primary care practice in your area, it may be difficult. But you know, maybe you can find someone else who might be able to sort of meet your needs. And when I think the piece about why are you doing that with the, you know, the remedies and things like that. I think, and for a lot of people, I think if you were a physician or clinician, maybe the way it's delivered, maybe it could be like, tell me more about that.
Exactly.
Not like, why are you doing that? It's like, tell me more. Because, you know, I'm Black, but I don't know every cultural thing and for all Black people. It's like, but it's kind of like, you know, tell me more. So what's, you know, so I think that even how people are engaging with someone in a caring and you want to know more versus like a judgmental, like, why are you doing that?
Right.
I think makes a big difference. So looking for somebody who can just sort of meet you where you are and be empathetic and open to listening to your experience. they still could be, Asian or
whatever it might
or
be,
white
right.
or whatever. But I think if they have that sort of cultural humility, which
That's
I
the
think
word.
we have to acknowledge that, okay, we're not going to have,
Knowledge of every
enough.
culture.
Yes, we're not going to have enough of us
Right.
to see all the black people or all the brown people. But I think if we can kind of raise awareness and help train, I hate to use the word training, but just,
Develop and educate people.
yes,
Mhm.
educate
Yeah,
people on that
gotcha.
cultural humility
That's
piece,
good. That's good.
then we're all good.
yeah, that's
So,
good.
yeah.
And I would go off the same thing in terms of if you have a primary care provider, you're able to establish a relationship with them.
Right.
Them get to know you and you get to know them. And I think by having those conversations on, well, tell me more, they get to know more about you, more about your culture.
Right.
And again, not to say that every black person they see is going to be the same in terms of the treatment, but again, it gets them to a conversation and it also gets them to be like, oh, these are some stereotypes and judgments that I've had that maybe I need to work on. And if we just come into the healthcare office and be like, all right, whatever the doctor says, I'm going to do, and not really having conversations and engaging with them, then that's not really helpful either. So advocating for ourselves is important. Doc, you're not listening.
Right.
Doc, you're not listening to me, especially when it comes to our black females and black pregnant females, and we have seen disparities among this. They need to be listening to us so that we can create some changes. And I also think, and I heard you mentioned this earlier, like going to urgent care or going to the ED and necessarily waiting till something gets really bad isn't the thing that we want. Because by the time you go, it may be too late for something, right? Unless we feel an ache or pain, it's usually that's the time that we go. But blood pressure and having high blood pressure is usually silent.
Right.
And it gets to a point when you do have complications, it's like you having a heart attack or you're having a stroke or you're having an aneurysm, and then that's too late. So prevention is key. Health promotion is key.
Right.
Having a relationship with a provider is key.
Yeah.
And someone you can say, yo, that's my doctor. I know him. I know her. I know they, if you're talking about pronouns here.
Yeah.
And that's, and that's who I want to go to. But yeah, it's important. Relationships.
That's good.
That's real.
And I think the relationship piece, thank you, extends beyond the individual. I think health systems, like, big hospitals and whatever, who have clinics in places, I think they also need to be engaged with their community members to kind of listen to what is working or what could be helpful.
Yes.
Because they can be the partners in health promotion
Yeah.
and recruiting, diverse staff and things.
Yeah.
So I think that's also a big piece too. That's the systemic piece, right?
Yeah,
Right.
that's huge. I'm gonna go ahead and take a dive now and just say this out loud. That no, honestly, because I'm not at work right now, so I can say this. I think the one of the best things to do, especially for the health system that I work with, is we really should be diving into community health workers, right? And that's something I'm learning about more now. Is that we need to fully invest into that. Like the community needs to be, and we should be there, meet folks where they are, and then create access to resources, provide the resources, provide the health literacy in a way that folks say that we need it this way, not a prescribed way, but let's do it in partnership.
Right.
Yeah, so
Right.
I think that's right. I think that's right. That's huge.
Exactly.
Yeah.
And that gets to kind of that prevention. If you do that in the right way, right? It kind of builds that trust that has been, broken early. So that's good.
Yeah.
And I'm sorry.
You're not sorry, but outside you're not sorry.
Listen,
You're sorry.
I see his the side eye. He's like, oh, maybe Mo wants to say
Right.
something.
Oh, sorry, Mo. Oh my
Listen.
gosh.
As a therapist, you do not just cut people off. You
you gotta dive in. You gotta dive
you take in
in.
what's being said.
Okay,
You
go
feel
ahead.
me?
Go ahead,
I was
go ahead, go
just gonna add, outside of the relational piece,
yeah, talk to
because
me,
there
talk
are
to
some
me.
people who just do not want to over speak with a doctor or a stranger or person they don't know. But the data collection is so powerful. So if you're continually going to your PCP and you're seeing your numbers go up or change or things, it's like for you to know something might be wrong.
Yes.
And then from my therapy standpoint, I like to do genograms and understand who who in your family had what was going on, if it's a mental thing, if it's a medical thing, and bring that awareness, because some people just don't know. It's like, oh, my great grandfather did these things too. It's like, oh, maybe I should get checked because based off how he died, this was a problem. And a lot of people just have no clue about their family history, about what is going on in their bodies and everything. So yes, prevention, the data. I was just saying, I agree.
And you know what's so? Oh wait, so listen, y'all. For the rest of the podcast, Mo just got this. You just jump in there, gang. I'm sorry. Okay.
Oh,
my bad.
go ahead. Oh,
No, you got it.
No, you just reminded me of something. So, we we have family histories of different things like, breast cancer, and my mom, my both grandmothers, both my sisters, and, heart attacks and things and strokes. But it's kind of one of those things, I think it's up to us as parents to kind of inform your kids,
Yes.
because
For
I
sure.
actually kept some things from my kids.
Yes.
Thinking I didn't want to worry them
Oh,
or
my
whatever,
goodness.
and then
Oh,
when
my
they
goodness.
found out, they're like, "Why didn't you tell? I didn't
Right.
know Aunt so and so had breast cancer or whatever, depression." And I'm like, "Oh," but now I know
Yeah.
that we can. It's good to tell them, especially the mental health piece. I mean, it's just like people don't want
But
to talk about that or
I'm
whatever.
going to piggyback
Yeah.
off that too. It's important when we start dating folks, because things like sickle cell disease and sickle cell trait, you get with someone else who has the sickle cell trait.
Yeah.
That can mean your baby has the sickle cell disease. And what
Right.
does that mean for that baby? So even just in having conversations when you're in a relationship about what's your family history like?
Yeah.
What's your family history? So if we have a kid and that kid now develops some psychiatric disorder or heart condition, we know where that's coming from. And I don't think relationships are really having those
all.
conversations.
Oh,
I don't
no.
know. So
Yeah.
I think it goes deeper into
Yes.
the why,
Yeah.
because you can now start to have those family conversations, that pre-planning family conversations.
Right.
Ooh, this is that
Right.
heat right now. Hey, no,
the
listen,
heat.
this is heat right. Well, you know
hot
what?
in here.
That's good. That's the heat.
Is that a song? Something about a song? It's not, it's
Yeah,
not-
Nelly.
Hey, I see you. Listen, come on now.
I can't sing, so I'm not going to try. I'm done. Yeah.
So I want to pause on that and stay there before we move to the next place. It's like our cultural practices outside of just health affect our health. So a lot of, I think a lot of times, and not all the times, but often in the Black community, sharing information or communication in that way, like you just spoke about, is almost like a forbidden, like you don't do that, right? You don't. And as kids, you're also taught to not ask. It's
Exactly.
like, right? And so
Exactly.
that, and you're so right. Like I found out, like one of my my uncles had prostate cancer. My other uncle has prostate cancer, and I'm finding that out now. And I'm like, okay. Thankfully, it's now and not. But I didn't find out through means of let's sit down and talk about this, right? And I think that's a huge piece of it. Is how we communicate within the family so that folks know things. Because oftentimes we're doing it for the right reason, right? Like you said, I want to protect. But in reality, I think in the long run, you're almost harming more,
Yeah.
right? And it's not intentional.
Right.
And I think the other factor too, as like the history behind why that is sometimes, and why we might not have the opportunity to communicate generationally, is a lot of the other social determinants. So our criminal
Exactly.
justice system, which has been historically racist, and how it has broken the family.
Yep.
Things like the war on drugs, how that has been historically racist and has broken the family. So we almost have been robbed in ways of the opportunity to do that.
Right.
Now I think as a society we're starting to make some progress, right? But we can't carry those old traits with us. Like we have to stop that, because that was a point I didn't even think about. But that's huge though, and I've seen it in my
Yeah.
family. Like,
Right.
we don't talk about a lot, you know.
But I'm glad, Herb, that you said that, because it's just not like, oh, Black families don't want to get together and talk. It's the structural influences that have been created, the war on
Right.
drugs, like you said, the criminal justice system,
Right.
the fact that mom or dad needs to work 2-3 jobs, so they may not be able to be there. They got to leave dinner on the table.
Right.
You know what I
Right.
mean? Like, it's not just we don't want to talk about these things per
Right.
se.
Right.
It's the opportunities to do so weren't necessarily created for us to do that easily.
Right.
Yeah, that's
And so
good.
then that's
Right.
when we go to our friends and learn from their parents, or our older friends and learn from
Right.
our older friends certain things, or
Right.
nowadays just get that information from social media.
Right.
yeah, that's good.
Yeah. Dr. Facebook.
yeah,
Yeah.
yeah. No, I think, and in my experiences, unfortunately, with trial and error, like that's how I
Yeah.
learned. I think that's not the way.
Yeah.
Right. I would say.
At all.
And so yeah, you're right. It's not. And I'm glad you pointed that out. It's not just like, oh, Black folks do this just because they're Black folks. It's no. It's not just the race. It's the racism. Or
Right.
It's not
Exactly.
like this is
Okay.
like
Right.
someone's gender. It's like the sexism. It's the
Right.
things that come
Right.
from that, not just because of the skin color. So yeah,
Right.
I think that's good to talk about. That it's not just because we Black folks.
Right.
Yeah, it's
That-
just not. Just,
right.
Yeah.
It's
Right.
the system.
Yeah.
Yeah, that's some of the work, Dr. J, you do. I hope you don't mind me sharing this, but I know that you work with Firm, Fighting Institutional Racism in Medicine. Yeah, she worked with a group called that.
That's
yeah.
right.
That up.
Racism is in the word. Yep, that's right.
Yeah.
Yes.
So you all do a lot of work with that. Yeah. So
Yeah. It's just, there was a few of us from Ithaca, local physicians and nurses and community health people that were just, after George Floyd and just with the pandemic, we're like, we have to do something. And we've been talking a lot about, getting like some sort of diversity related thing, even at CMC.
Oh, you good? No, that's good. No,
Okay.
you good.
Even at the local hospitals and the health system.
Yeah, you good.
But we were like, okay, we're just going to do it ourselves and just kind of do something and start. And yeah, so it's been maybe a year, a couple. I don't even know. It's all a blur.
That's good. Yeah. No, CMC ain't got no gag order. Like we can bring it up. Nah, you good. You good. She wanted to make sure. Like, and her about to get fired over here. Nah, we
The
good.
best part is people are like, "What's CMC?" Because I was like, "What are you talking
Rochester,
about?"
Rochester. Don't worry about it. It's fine.
Yeah, don't worry about it, y'all. It's CMC.
Yeah.
We ain't gonna tell y'all what that stands for, but if we want to talk about it, we could put our foot down.
Girl,
Yeah,
but it's just part of just trying to encourage change and in the for the community on behalf of people hopefully in healthcare who can actually make some changes happen and stuff. So so it's important, and this is part of the community being part. We're part of the community, so we need to be part of the community.
Yeah, that's good. So it's good we talking about that because I want to bring up some numbers so folks see we're not just talking, right?
Just
Like
not
this
talking.
is the stats, right? So bringing up some health stats because we talked about health equity. And folks that don't know, a very basic way to describe that is a push for health outcomes that are not worse for marginalized people than the rest of the population, right? And so it's like equity is so many different factors that go into that. So we can't dive into all of them, but that's the core of it is folks should be able to access, experience, and have healthcare outcomes that are good and positive for everyone.
For everyone, right.
It should not be the way it is for the marginalized groups, right? And some of these numbers that show that is right now, Black folks have the highest infant mortality rate and maternal mortality rate in the nation. It's almost double. Well, it is double, more than double of their white counterparts, right? For both the infant and maternal mortality rate. So when you think about that, people hear numbers like that. It's like, oh, no, those are real mothers and real babies. Like that's real lives attached to that. It's so easy to hear the stats and just hear numbers, but no, those are people that we know. So yeah, also beyond that, and we talked about some of the social determinants. Minority youth, so Black and brown youth with behavioral health issues are more rarely referred to juvenile justice system than specialty care, primary care, or any type of mental health institution, right? So we end up in jail, right, with other folks. And if you go, an example of that would be the crack epidemic versus now the opioid and how that affects
For sure.
the white community more. And so a lot of this is, we need to heal and restore and reconcile. That did not happen for us in the same way, right? Just a few more. That's tough to go through. The risk of dying from low-grade prostate cancer is double for Black men than of any other race, right? And so low-grade, and we got the healthcare professionals here. I would say low-grade means not as aggressive. Is that right? Okay.
Right.
Okay, pass the test, y'all. And white women, last one, are diagnosed with breast cancer at a higher rate, but Black women are almost 40% more likely to die from breast cancer, right? So just hearing all those numbers, I would say two quick questions. First is, what steps do you think healthcare systems in general and places that you all have worked or experienced, what do they need to do? Because these numbers are a reflection of us, right? And what we're doing. What do they need to do to make some changes?
Listen.
Yes.
Pause. Just listen and pause. Stop trying to do for and instead do with, right? Like, many major institutions out here coming up with these policies and procedures and getting this grant money and doing this, and they not including who they want to give it to. They're not giving it. They want to do research on certain communities, but they not giving to these communities. They're always doing for, and just pause and listen to the groups that you are trying to do work with, I think is an ultimate first step. And I'll just pause there.
Yes. I totally agree. And I also think the sort of the stats you listed are also account for, insurance, like insurance coverage. So just because I'm like, got my good insurance and stuff, and if I'm a pregnant woman, that doesn't protect me from having a higher mortality rate. So that's, I can be, the CEO of whatever and still have, Serena Williams, right? Did you hear about her whole ordeal?
Talk about that. Yeah, talk about that a little
not
bit.
listening and not, So it's just, so it's not like, if they, had better insurance or somebody had, it's not that. It's across the board, regardless of insurance and socioeconomic status.
Yeah.
Right? So it's.
Yeah. And when you look at the numbers and control for those things, you're right. Because when you control for all of those factors, there's still disparities. Like when you control for insurance and you control for all those things, still disparities. Yeah.
Exactly.
Because add that if I was thinking of it more of a doctor level, that the reorienting toward just clients isn't there, or patients isn't there, because like everyone in any profession takes the oath of do no harm, right?
Yeah.
But everyone only thinks about it intentionally. No one really thinks about the unintentional harm that you may be doing. And I like you said, just the listening. It's like, no, actually focus on what the client or the patient needs, because I see it so often where physicians or providers are just so focused on what they need to do, not what the patient is actually needing. So they don't hear them when they say I'm in pain. And you hear all those stories of those pregnant women who, after they had the baby, something is wrong, and people have to fight for someone to hear them, or they say, no, you just want drugs, so I'm not going to give it to you. And they're in severe pain and may die from whatever, because no one actually checks or takes the time. And I'm like, no, commit to reorienting to what the patient needs, you know? That's
That's on point. And actually, Black patients are 20% less likely to be prescribed pain medicine for similar illnesses. So
Yes, there's a University of Virginia study.
Yes, talk about it.
Yes, I think 2015, and it basically it was several other items of that were surveyed and things, and these were like medical students and residents who really. So this has to do with how a Black person's pain is perceived, how severe.
Yeah.
So some of the things that were definitely incorrect but these are things that students thought and residents thought, that black patients had thicker skin, our nerve endings are less sensitive, our blood coagulates quicker. So that we don't feel as much pain. So we don't, that 9 out of 10 is probably just like a spot.
Right.
Wow.
Right.
Yeah, but the pain is key.
Right.
I mean,
Wow.
it's just, it's crazy.
But then you take that and go back to historical times when different experiments were being performed on this without anesthesia,
Yes.
right?
Yes.
Henrietta Washington has a book called Medical Apartheid,
Yes.
okay,
Yes.
which talks
And
about a lot of the
yeah.
experimentation that had been done, especially in the history of GYN with Dr. Marion Sims, who's the father of gynecology, and was doing all this stuff on slaves like Annabelle and all these other names who they weren't
anesthesia.
doing weren't using any anesthesia, right?
Yeah.
They were thought they couldn't feel pain.
Yeah.
Their body could tolerate these things. Those things have been passed down in medical and nursing curriculum for years, and these are the things we're pushing back on because it has to
Right.
stop.
Yeah.
It has
Exactly.
to stop.
Exactly.
That's so good.
Right.
Yeah, and that's right. And another thing too with the history and how that flows into now. I'm all the technical terms, y'all gonna have to help me. But I talked about this in the presentation not too long ago. And I told my dad about this. He was blown away. He's actually kind of pissed off. So there is and I'm gonna give it how I would want to receive it as just a regular person, right? So just recently, just changed this, right? But before, the way when folks went in to get their kidneys checked, their kidneys looked at, right?
Yes.
And I would go in, and there's a variable. Pretty much, you go in, and when you get your level checked out for your kidneys, and this is how I'm gonna explain it because this is how I want to know it. There's a threshold that says, hey, past this certain threshold, you need to go get either follow-ups, might be something serious, whatever that might be. There's a selection when you're checking for these levels that is a Black variable or a non-Black variable, right? If you select the Black variable, then the threshold is now wider for you, which means that us being flagged to say, hey, you might want to do some more follow-up, this might be something serious, will be longer or a later wait, right? Delayed more for us than someone else of any other race. And then when you go back and think about something called the Virginia Notes by Thomas Jefferson, he talked about how, and this is the origins of stuff like this, how slaves, Black people's kidneys, they didn't function the same way, which is why they smelled worse. They could, all of the things he put into that, right? And so if you think about how that was passed down generationally to now, and you see something like systemically like that, which just, I want to say in 2020 or 2021, that was just started to switch or change.
Yes, they got that race factor off of the the creatinine, and yes.
Okay, all right. So,
but it's a kidney function. It's just a measure of your kidney function,
Right.
And
Yes.
so finally, that is not any longer shouldn't be any longer part of how you measure function based on race.
Yeah. And when I think about that, it's like, okay, great, that's changed. How many people did we lose or had a serious condition because of that systemic thing? Like that to me, that's a class action lawsuit, right? But I'm just saying, I won't put that out there. But I'm just saying, right? In all honesty, there's people who have lost loved ones,
Exactly.
or had some serious ailments because of this systemic. And how many more of those are there?
That's the thing. How many more are still out there that has to be challenged and gotten rid of?
Yeah. So, okay. Anything? What else anyone want to add to that? Say hi. Like I did that. I'm learning, y'all. Okay. Anyone want to add to this? What is just before I know we I can sit here and talk all day. This
I
is
just
good.
had a quick question though. I wanted
Yeah.
to know if there is a resurgence of like home births, or are you seeing more women push for that just based off of how dangerous it has been in the hospital? Now, like people are looking for doulas more and things like that. And I mean, I don't have kids yet, but I'm not gonna lie, I'm thinking about it.
So I would say in Monroe County, specific to Rochester, there is a doula collaboration that is going on, really pushing for efforts with increasing doulas and certification doulas, and that is with Sharita Bullock, and I'm drawing a blank on the name of her organization, and I will come back to that. But they are training doulas, and even speaking of policy, Senator Schumer was here about 2 months ago and really pushing for increasing Medicaid coverage for postpartum. So after you have your baby, pushing that to be covered for 12 months.
Oh, wow.
Not 6 weeks
Right.
postpartum, 12 months. Why?
That is awesome.
Because people aren't listening,
Right.
and
Yes.
complications are happening
Yes.
way past 6 months
Right.
of time. Healthy Baby Network, is the organization here.
nice.
And the other thing is to have Medicaid cover doulas, because right now it is an out-of-pocket expense. And so when we
Oh.
talk about changes and wanting doulas and all these things, you have to have policy change
Right,
with it.
right.
And so advocating for policy change is important.
Right. Because I was
Awesome.
reading something where it's just like the way you deliver in the state or in these states, it's not actually conducive for what would help with a baby, like standing, kneeling, like bending over. Because gravity helps also. It's like all these things. And there's so many complications, or a push for even just getting a C-section.
C-section.
It's like, of course, it's a surgery. It costs money. It's like, well, great. But no one really wants that because naturally the baby should come out. But then I heard doctors are taught to check this way with people laid back on a bed. So that is why they have them in that position to have a baby. But is it the best way? You know what I mean?
It's not the best way for our bodies to deliver.
There's so
No.
many things. But that's all I wanted to know.
Good.
Also, midwives haven't been
yes.
mentioned much in this
Yes,
conversation,
yeah.
but doulas and midwives, and then your actual obstetricians as well.
Yeah, so I have not done OB in like billions of years, and I see mostly college students, so I have no idea what they're doing out there with the birth thing. But I think, but that makes sense to kind of expand so that coverage and other ways of delivery options. You know, you have to hear about birth centers and things like that are less, But of course, home births, home deliveries and things. Definitely, if you depending on your risk, probably.
Your risk,
if you have like issues with previous pregnancies, you probably want to be closely monitored. But definitely for most women,
Yeah.
no,
That's good.
I'm not sure if I would. No, I just nothing. I'm like, I don't know. I'm thinking like, would I want to deliver at home? Oh my gosh, I don't think so. But for those who would, absolutely.
I would love to if I ever,
Yeah.
and I ain't trying to have no more kids, but if I ever have more kids, like my son 22, ain't no need to have no more, but
That's fair. That's fair.
That's fair. That's fair.
like
Fair
I'm not
assessment.
starting over again, but I would consider having a doula or a midwife and someone. A doula is there to help with that emotional, psychosocial supported delivery, not the medical that a midwife or OB would do. And so a doula provides that other support, even with meals, being there for the birthing partner. Many times the birthing partner is felt excluded when the provider comes in there, like just focus on the woman, and the male or the birthing partner, which could be a female or however they identify, can be in the back corner and not know what to do. And that doula is there to support them, that family unit.
Right.
Okay. That family unit that was talked about earlier. And so I think it goes back to advocating. I mean, we ain't here to talk about all the other stuff, but just reproductive rights in general and women being able to advocate for themselves, and
Exactly.
Black women in the history of reproductive rights, and being able to advocate for yourself is just so important.
Listen, we talking that talk. So I want to ask this too, and this will be the last question before we kind of give some final words. But I think we all are, in a way, like I said before, working in healthcare with health in general, right? But it sounds like we are doing equity work just because it's a part of our lives. And not everyone has to be passionate about that. So let me say that. Every person you see that's Black and brown is not your DEI person. I'll go with all your questions because
you.
that is not their role.
Yes.
Right? So let's do that. Save us that. But for some of us,
Save us.
some of us, we actually, like for me, it's like, yeah, that's my role to educate, right? And it seems like that's what we're looking to do. The other side of that too is a lot of these things that we're talking about when it comes to health in that way, those numbers are us, right? Like those numbers are our families. The numbers are our people that we know. So how how do you navigate that? And this is more of a personal question than a professional question, but like, how do you navigate knowing like this is, like we are living these things on top of trying to have to work through those, right? Or educate on those. Like, how does that affect you all?
Mo, you want to start?
Yeah.
Hey, let's go.
Yeah. All right.
Thank you. I
Yes,
feel so
yes.
loved on this
That's
side.
so, yeah. Thank you. That was awesome.
I have chosen to be a cycle breaker. Like I push myself to do the things that I wasn't necessarily taught or raised to do. And so maybe I'm a guilt trip to my family at times, but I push to get my health in order, and I push to always go see the doctor, or whatever I learn, I try to bring back to my family all the time. And they don't necessarily want to listen because, you know, we are creatures of habit and everybody wants to do what they usually do. But my family is more than respectful and will actually hear me out. So if I'm around, I'm like, I'm gonna make you this, or like we should try doing this, or like go on a walk for me or with me, and then like checking in, like, hey, how you been feeling? That seems like maybe you should be drinking more water. Have you seen your doctor yet? Like really pushing that those around me are doing the things that I think we all need to be doing to keep our health here, because like life is so short. Like everyone is just going, and sometimes the only time you see people or you learn something new about your family that could be a concern is at a funeral. And it just keeps happening. It's like, nah, at some point we have to make a choice or a decision. And if I have to be the one out of the 50 for right now, I'm going to be the one, because eventually there'll be two. And then there'll be, you know what I mean? It's like, I'm just going to keep pushing that way.
Yeah, that's good.
And I agree with you, Mo, as far as, you know, breaking sort of those cycles. For me, it's about the education too. When the COVID vaccines first came out, me and my cousin, who has her master's in public health, she's an epidemiologist down in New Orleans, we had a family Zoom call. And there was about 15 family members on the Zoom call, from our aunties and uncles to our great uncle to cousins, to educate them about the different types of vaccines. So we were bringing that knowledge to them. And that goes back to, well, I know my niece ain't going to tell me nothing incorrect. So that trusted person that you can go to and get information from. And so that's where I'm leveraging what I know is, I know my people trust me, and they're not going to think that I'm out here to harm them. And I'm not out here to harm you. And then when it comes to conversations with my son, he has yet to receive the COVID vaccine, and, you know, that's his choice, but I still educate him on, you know, those things. And like you said, let them make their own decisions, but bring that education to them in a way that they're going to be able to understand. Even with meal prep, you know, I'm a vegetarian, I'm pescatarian, my son is vegan. And so even introducing different foods to our family during Thanksgiving. Well, we can't have that turkey with the dressing, you know, those type of things. Like, what are some other things that we can do? And then having those conversations about the history of culture and our food, and how we can sort of change things, and then got to use all that seasoning, salt, etc., and just begin to have dialogue.
That's the hard one for me.
Agree. And I think for me, just remembering that, you know, I deserve, you know, to be as healthy and well as possible, right? And I would, you know, instill that sort of same thought to my, you know, family, you know, my immediate family, because I think that a lot of us sort of, we're so busy and we're like, oh, we'll put it off. Oh, you know, it'll be fine. So I try to be intentional about, okay, let me get my, you know, annual whatever, or if I knew if something's off, I've been better about this. Get it checked out. It's okay. It's not, I'm not going to be a bother to the doctor that sees me. It's not going to be, you know, it'll be fine. And just knowing when to seek care, and knowing sort of the difference between, you know, oh, it's probably just a little strain versus, oh my gosh, I might have done something serious. I mean, this just so, because I want to be able to be as functional and active as possible. So I want, you know, even in my later years, and be there for kids and, you know, grandkids, not anytime soon, because that's a whole other stress. But and just encouraging, like, even my family members who, you know, my dad, who's up, you know, he's over 80-ish now, and just, you know, if something's not right, get that checked. You know, my sister, go get that checked. So, you know, we all deserve to be healthy, and we all deserve to get stuff checked out. And be heard and be listened to. And if somebody finds somebody that can't be there for you, for whatever clinician or provider, then you move on to the next person.
Right.
Yeah.
But just being that, advocating for yourself and your own health and wellness and mental health too, because I think sometimes there's like, oh, you're fine, you're not
Right.
which
Right.
is something that we've had with my kids, where I'm like, why are you? What, they don't think there's anything going on, and then but anyway, so there's a whole other discussion about that.
Yeah.
But yeah,
I love that, and I almost think like, so hearing it is almost like the way we've dealt with having to do that is we've educated people around us, like our spheres, to do different and do better, and I think that's right. That's and that for me is like with my family for sure. It's definitely, I'm trying to, as I learn more, and it's been a short period where I've been in healthcare, I've been on people. Like, she know, I'm like, yo, you got a primary care. Like, once I learn,
you got a primary care.
Listen, I'm not playing. Like, once I learn that is the best, like, that's the prevention piece before it's like, oh, I'm like, what? Urgent care ain't savior? Because that's what I thought. I thought urgent care was everything.
Mr. Doctor Shake It Off. Like, I always had a PCP as an adult. You coming at me. I was like,
listen,
do you have one?
Yeah, I'm like, I got one now. Yeah, because I'm learning it now. It's like, oh, that's so. Even with my dad, I'm on my pops because I'm learning that. And the person who really showed me that it's one of our leaders in our health system, Dr. Delimo. Shout her out. We were talking about something. Yeah, and she was like, and I said, well, what can we do? That's before I knew what I knew a little bit more. I'm like, what can we do for like prostate screenings? Like, we want to get people in, like do some type of like the PSA test and whatnot. She's like, well, to be honest, like that's a snapshot. You really want to have a primary care doctor and like check your numbers over time and have a relationship. That's more important than just popping up. It's like, so you can give people like false hope. Or do you really want to do the right thing?
Right.
Okay. So I called my pops that day, like, hey, pull up to the doctor. I'm like,
pull up to the doctor.
Go right now. I'm not playing.
ASAP.
Yeah.
But I think Mo talked about this earlier, that data, and you just hit on it too. When you as a patient are able to see your information, it gives you something.
Absolutely.
You can then go in and be like, Doc, I don't know if you saw, but my numbers over the last 3 times I've been with you, and they can look and they may be like, oh, you right. And now you feel like, ooh,
empowered.
That empowerment, right?
100%.
I caught that. I did that. And that's what we need to give back to our community too.
Oh, the whole, I mean, there's a whole like, I forget the name of the act, but it's something where not students, patients should have access to their records and to their lab work and to their progress
chart.
notes.
All that,
I mean, the Navy, we carried our charts around every time we moved duty station, so I could always flip through mine.
Right.
And I'm like, all right. Yeah. So it's just and the medical documentation is for like the clinician to kind of it's not necessarily for like easy casual reading for the average patient, but it's good to be able to see your numbers and see trends, and I think the transparency of, I think it is powerful that someone can actually be able to know, okay, this was my blood pressure last year, and this is my, CBC, whatever, blood counts and whatever people may be following or not following. But I think it's huge to be able to, because you're a partner in your own healthcare too, right?
Yes.
That's what it's because you have that knowledge.
Advocacy, yes.
Yeah, and that's 100% what I've been trying to do since I've been learning. So I appreciate y'all sharing that. And then the other thing too, I'll say this last thing is, and for anybody in that space, I think, because I did not come up in healthcare, I think one thing that's key that I try to do in my role is understanding like health literacy and understanding the terminology and what's happening is I would say it's one of the largest barriers, like the gateways for people to be healthy, because understanding what's happening is huge. And so trying to break things down, like the way we explained the kidney levels, right? Like, oh, that would make sense.
Right.
If you talk about the EGMFR and all that, like that's what the thing like, nobody's going to whatever it is, right? I don't know what it is.
I don't know what that is.
Yeah, thank you.
Glomerular filtration rate.
Thank you. So it's like, hey, so if you say that to me, it's like, okay.
What does
My point exactly. Right.
How your kidneys filter out.
Yes.
Your glomerulus
Yes.
is part of your kidneys and
Thank
the
you.
anatomy structure, and
Thank you.
filtration rate is a calculation of.
Thank
to
you.
know.
There we go.
And things like that. So and even with that, I heard a story where someone went into a patient and was saying, yeah, so this was going on. You have bilateral pneumonia and blah, blah, blah. Patient left. Didn't know what in the world So that means, you got ammonia in both your lungs.
Right.
Okay, patient had no idea what's going on. So it's things like that to where as we exist in the space, it's normal to us, but folks won't know that. So it's just breaking down. I think that's another key
Taking
in
the
that.
time, to actually explain. Yeah.
Right. So that's one of. So this is my last thing. That was like my final words to folks. But anything you all, if you could leave some few words for our community, things that we should know, what would you end with for people to take with them?
Document. Like, ask for documentation. So like if you go into a doctor and you're like, I saw this on TikTok. Don't think I have.
TikTok. I saw that
I'm
TikTok.
not even on TikTok, but IG showed me
I'm
TikTok.
not on TikTok.
Right. But like if you go in and you think something's wrong, you think something's up, and the doctor's like, it's probably not that. I think you mentioned that earlier. Have them write it down. It's like, okay, if you are refusing to give me this test on this, or you're telling me that it's not that, please document that in my chart so that I can see that as well, and any other person. And sometimes the doctor be like, you're right. Let's just get these follow-ups. Let's do like, yes, because if you're claiming that there's nothing wrong, but I'm telling you something seems wrong and you don't want to check, write that down. Clear as day for me.
Wow, that's a good one.
I think the EMR has caused our healthcare systems and providers to have to step up their game and do a little bit better with documentation.
I was like,
there we go.
Oh, electronic medical record.
Thank you.
The one you have access to. Because then patients can see exactly, and they're like, we didn't talk about that, or we did talk about that, and have some accountability.
Yeah,
That's a good one. That's a good one. I mean, I think it's just a matter of kind of I'm going to be a broken record, but just you have a right to be healthy and as well as possible. So advocate for your needs.
Yeah.
I mean, that's the biggest thing. Don't be afraid. I know some people, based on your culture and historicals, context with, the medical community, but, just get your needs out there.
Yeah.
And I don't mean like being prescriptive about, okay, I need penicillin because I have a sore throat, but you don't have strep, but I want penicillin.
Right.
I'm like, or antibiotics. I'm like, yeah, okay. So not like that, but
Right. You ain't the doctor, right?
I mean, you really don't need antibiotics because you don't have a bacterial infection, but kind of being that active participant in your own healthcare, and then you and your provider are partners.
Yeah.
Because ultimately it's your body, right?
Yeah.
It's your health and wellness, and we're here to kind of help you,
That's
right?
good.
So I think that's a big thing to sort of remember and provide feedback, to your healthcare facilities.
Yeah.
And I know sometimes it's hard to like give feedback that may not be necessarily all glowing, but in an ideal world, and hopefully places can get better at that, but just really being able to address the concerns of their community.
That's good.
Yeah.
And I think I want to leave with, to the listeners, if you are white, this is your time to take the feedback and think about how you can use your privilege of being white, how you can be an ally, if you are healthcare, how you can infiltrate the healthcare system using your privilege to make changes for those who are marginalized and oppressed.
Sure.
And if you are a Black listener, hopefully you have learned a whole lot and can go out there and feel empowered and begin to advocate for yourself and begin to challenge sort of those issues that have been for too long prevalent in our families, and be the change that you want to see.
Ooh, very nice.
She
Let's
dropped
drop
that
that
mic. I ain't got nothing to add. Yes, girl. Mic drop.
Man, listen. So this was amazing, and I ain't gonna lie, people probably listening like, what in the world they talking about? Listen, we might be right, and today we probably are right.
We're unlikely wrong, but we might be wrong.
We might be wrong, but at the end of the
Probably
day,
We're just
young,
young, black, and figured it out.